Good morning again. I'm using this because we have people joining us online, and we need this for the audio for the people who are joining online. So we are delighted to all be back in the same room again. So many of you I've seen online for the past 3 years, and happy that we can finally have an in-person meeting here in Toronto. And we're having a few others in the upcoming weeks in other locations. I'd like to thank Robin very much for all of her organizational skills in getting all of you here safely today, and for setting up all the audio and everything. So again, thank you, Robin. I'm very pleased to introduce Dr. Yi to you, and she's going to be speaking to us on MDS this morning. Dr. Yi has done a number of presentations for us over the years, and was delighted that she was able to be with us today. So I'll turn it over to Dr. Yi.
Hi, can you guys hear me? Yeah. So I mean, in the room you can, but I'm Karen Yi. So I'm one of the hematologists at Princess Margaret Cancer Center. I treat predominantly patients with acute leukemia or myelodysplastic syndrome, and I do a lot of clinical trials. Okay. So thank you for inviting me to give this talk. I was just going to present some updates or newer developments in myelodysplastic syndrome. And there's been a lot of changes over the last 2 years that people should keep abreast on. So these are my disclosures, mostly because the hospital receives funding for clinical trials that I do. So what I was going to talk about, since 2022, there's been 2 newer classifications that have come out with respect to myeloid neoplasms, including patients with myelodysplastic syndrome. And there's the traditional WHO or World Health Organization classification from 2022. And then this last year, there was a newer classification called the International Consensus Classification 2022, somewhat similar, some slight differences, but probably doesn't change what we're doing right now. And also, the International Working Group for Prognosis of MDS has come out with a newer IPSS score, and it incorporates genetic mutations onto that score, and they call it the Molecular International Prognostic Scoring System, IPSS-M. So we'll talk a bit about that. It's a much more complicated to decipher scoring with that system than the traditional IPSS and IPSS-R. And then there's also been a bunch of treatments that have been approved, probably in 2020. And then there's been a slew of phase 3 studies that have either completed or just one of them just starting to enroll. So we're waiting for some results to come out of that. But those studies may lead to some game-changing treatments for patients with MDS. Okay, so probably to highlight the fact that I think all of us that treat MDS and myeloid neoplasms have been pushing the government to get funding for more genetic mutation analysis performed, just because it affects the way we make a diagnosis, the way we do prognostication for patients, and also decide about treatments. So the government, Cancer Care Ontario or Ontario Health, has funded as of December the 1st, 2022, to do extended gene testing for patients with newly diagnosed. So it doesn't include patients that were previously diagnosed, but newly diagnosed cases of myelodysplastic syndrome, myeloproliferative neoplasm, and also the overlap syndrome. Okay, so they've also recommended a number of genes that should be on any panel. Okay, and on the right-hand side is what we're using at Princess Margaret at my center, and they developed a version 3. So we've already had a version 2 and 1 that started rolling out when we started using next generation sequencing for AML patients. So that was back in 2018. And in red are the newer genes, and it pretty much it incorporates all the genes that are required for IPSS-M scoring, except it doesn't take into account like copy number changes, and also if you have duplications or large insertions into the gene, just because of the way the technology is done. But there's some other stuff that we're looking at to overcome that. Okay. But that's probably going to roll out at the end of April, but we still have the older panel that we're using. And the only thing, the caveat is to remember that Each center, depending on where you're at, will have a slightly different panel. So I think it's probably important to see if all the genes are on it. They'll have all the CCO recommended genes, but I don't know what other genes they have. And it may be a slightly different panel, like with also translocations and all that incorporated. So what I had talked about was, so that is helpful for using the newer classification for MDS. And really, I told you it was the WHO classification, ICC classification that came out. So this is just a slide just comparing the older WHO 2016 classification that all the hematologists were using to diagnose, myeloid neoplasms. And then on the right-hand side of the newer WHO and ICC 2022 classifications. And really, I think the whole point of these classification systems was to categorize patients into smaller refined categories based on morphology, cytogenetics, and to give some idea of outcomes and prognosis for patients, okay? So the only genetic classification based on the WHO 2016 was really MDS with deletion 5q. With the newer two classifications, the WHO and the ICC, they also recognize two other entities, which is the MDS with SF3B1 mutation, which previously was just called ring sideroblasts, okay? And they also recognize another entity called MDS with biallelic P53 mutations, okay? So, and there's some other differences, but the rest of it is probably semantics and smaller detail. But the rest of the classification is really based on morphology and immunohistochemistry. So I was just going to talk a bit more about the MDS with SF3B1 mutation, just because that also changes how we treat patients. So the diagnosis on your right-hand side, you're going to see just a Prussian blue staining for iron, and the blue arrows point to what these ring sideroblasts are. So they're just iron-loaded mitochondria that line up along the nucleus of the cells, okay? And it's supposed to be about 1/3 of the cell nucleus that it covers, but traditionally, before the mutation, you had to have about 15% of these cells to make that diagnosis of MDS with ring sideroblasts, okay? Currently, you can make the diagnosis with an SF3B1 mutation, and if you had 5% or more ring sideroblasts. And 80 to 90% of patients will have the SF3B1 mutation that have ring sideroblasts, okay? But so the difference between the WHO and the ICC is that the WHO still accepts the definition of MDS with ring sideroblasts, as long as it's 15% or more without that mutation, just to account for any other spliceosome mutations that we're not picking up right now, and that may come up. ICC does not recognize that. So that's a slight discrepancy. But I think it's sort of important to maintain because Luspatercept was approved based on just ring sideroblasts plus or minus the SF3B1 mutation. So a lot of these treatments that are approved are based on what was available at the time the study was conducted, okay? So the clinical features is that most of the time it's found in slightly older compared to the typical age of MDS other subtypes, and it's usually associated with a good prognosis and a good overall survival. And again, a proportion of those patients may respond to Luspatercept, and that's why we need that diagnosis criteria, and it'd be helpful with the SF3B1 as well, with people that don't have that 15% ring sideroblasts. So the second entity was MDS with mutated TP53. And so TP53 gene encodes a tumor suppressor protein called P53, and that's really a key regulatory feature of any cell. So when a cell gets damaged, either through radiation, chemotherapy, or other disruption of the DNA, what happens is either, the P53 helps in arresting the cell growth and allows the DNA to be repaired, or else it targets the cell for cell death. Okay, when you have a mutation in that P53 gene, you're going to not have a functional necessarily P53, okay? But you need two mutations because you have two alleles, two genes to disrupt all functioning, because if you just get rid of one of them, the other one could still function, okay? So that's why, at least in MDS, not so much AML, but MDS, you need both of them mutated or lost. So that's why they make a diagnosis based on the presence of two mutations or more on the P53 gene. And that's what the next generation sequencing panel will pick up. or else on the chromosome testing, you have loss of chromosome 17 or the short arm of chromosome 17 plus a p53 mutation, okay? And that's because the p53 is found on chromosome 17 on the short arm. So that's pretty much like both genes are being lost, and there's not going to be a functioning p53. So the incidence of this mutation, biallelic, depends on the type of MDS you have. If it's de novo, it's about 5 to 10%. It's not high. But if you've been exposed to previous chemotherapy or radiation therapy, then it goes up to about 40%. Okay. And we know that in a certain group of patients that have not so favorable cytogenetics, if they're complex cytogenetics, that number, 70 to 80% of those patients will have a p53 mutation. Okay. And the reason why this is important is because it's a group of patients that we don't have optimal treatment for. Survival is not, the best with the treatment we have available. I think the only potential would be transplant at this stage, but it's really not optimal treatment available. But there's a number, because it's a really unmet need. There's a lot of investigation in this group of patients, and really with certain antibodies that target things like CD47 or the SERP alpha CD47 pathway, and also something that sort of modulates the native structure of the p53. Okay. Next I was going to talk a bit about the prognostic scoring system. So again, there's a lot of prognostic scores out there, but traditionally the ones that fall into favor and that has led to drugs being approved is really the International Prognostic Scoring System. And it's gone through a number of iterations. The first one was 1997, subsequently modified, approved in 2012, and really more recently 2022 with the gene mutations. Okay. So this is just a comparison of the 3 different iterations of IPSS. So the first one was in 1997, very basic, really looking at 3 variables: cytogenetics, the blast count in the marrow, and the number of cell cytopenias, meaning the cell lines that were affected, whether your hemoglobin is low, platelets low, or neutrophils low. And it was simple as that. And it was so easy to calculate, but again, didn't give us that fine discrimination about who was at higher risk or lower risk of transforming, or else shorter survival. So they went on to the IPSS-R, where they gave a lot more breakage or breakdown to cytogenetics, and they, gave different cytogenetic changes for less favorable or more favorable. They also looked at when you had, anemia or low hemoglobin or platelet count or neutrophil, how low was low, because they're not all the same. If your platelet is 100 versus if your platelet was 10, it's a big difference. Okay. And the only thing is to make a note of, for the IPSS and IPSS-R, they use a blast cutoff of less than 30%. And that's really because of the old classification, of what MDS and AML was. It used to be, the target used to be, if you were AML, it would be 30% or more. Okay, and MDS was less than 30%. And that's what the timing of when these scoring systems were developed. But since 2016, AML is defined as 20% or more blasts, and less than that is still MDS. Okay, and that's why it's captured in the IPSSM, which is the molecular. So this is the first, scoring system that's an international scoring system that incorporates at least 31 different genes in it. Okay, and they look at all these genes for mutations. And they also keep the same cytogenetic risk groups that were used for the IPSS-R. Okay. The difference is they also included people that had therapy or secondary MDS. So if you had previous exposure to radiation, chemo, and you developed MDS, that group of patients were included. And it also included some patients that received treatment, whereas none of the other groups did. Okay. It gives you a risk group, one more risk group. It's 6 different risk groups. Okay. So I was just going to show you. So this is nothing you're going to be able to calculate out in your head. So they actually have developed an online calculator, that's that MDS-risk-model.com. Okay. And it incorporates, all the genes that I've it'll be on that web page. Okay. But it has 31 different genes. It still incorporates sort of cytogenetics, the type of cytogenetics you have, the blast count, the neutrophil count, the hemoglobin and platelet count. and you just get it to calculate the scoring system, and it generates a risk group for that person or that individual. And it could be one of 6 risk groups, either moderately low, low or very low on the left-hand side, or else it could be, moderately high, high, or very high. And it correlates with likelihood of overall survival and also risk of dying without leukemia. So if you notice that on the yellow, which is the very low risk, you see the high upper hand survival curve for leukemia-free survival and overall survival on the top, which is much more favorable than if you had a very high risk MDS, where it's the red line and it's much lower. Okay. But it's, you should have a look at what's involved in that, but it's not that easy to calculate out. The only thing is that this scoring system also allows you to account for missing information or information that's incomplete, supposedly, and calculate out a score. So what you get is an average score, and then you get a best case scenario score and a worst case scenario score. So sometimes if there's a lot of information missing, it could be, you could end up being low risk, but a bit higher risk based on that missing information. So it's undergoing world validation by a bunch of other groups to see how well this applies. Okay. So this is just, if you go on the webpage, that's what you're going to see on the left-hand side. I didn't push down the tab for clinical data, but it's the clinical data that I mentioned, the cytogenetics, and then molecular. I just showed a bit of the field, the screen, but it goes down further to incorporate a total of 31 genes. But it's really looking at whether you have that mutation, you don't have it, or it's not assessed. So it incorporates it that way. Okay, and then I was going to talk about 2 other treatments that were approved for MDS patients, and that was really approved and funded just recently, but approved in 2020, at least funded recently in Ontario, sorry. So one of them is luspatercept for lower risk MDS, Decitabine, Cedazuridine for intermediate 1 to high risk MDS. So this is just a timeline of how long it takes drugs to be approved in Canada compared to the States. On the top is the FDA approval. Health Canada approval is on the bottom. And I just split it up into the drugs that are approved for lower risk and higher risk MDS. And what you're going to see is obviously Azacitidine, which is still our long-term standard of treatment for higher risk MDS patients, was approved in the States in 2004. Based on an earlier study by Dr. Silverman, and then subsequently they had a much more international randomized study that was published in 2009, which showed this difference in overall survival, and that's what led to the approval in Canada and in Europe in 2009. Okay. And then lenalidomide for deletion 5q MDS was approved in 2005 in the States, in Canada 2008. And then what you're going to notice is Decitabine, which is a similar drug as azacitidine. It's a hypomethylating agent, was approved in the States in 2006. It only got approved in Canada in 2019. And the reason for that is because the drug changed hands so many times. And the companies were not interested in trying to get this drug approved in Canada because it's a smaller market. Okay, but they subsequently got it approved in 2019. But the clincher is that by that time, you had a generic approval and also the company that made the drug approved. So it's actually approved, but they've never sought to get it funded by the Ontario government or throughout Canada. So you really can't get the drug. So what came out in 2020 was luspatercept and Decitabine approval in the States, and really Decitabine, Cedazuridine approval in Canada in 2020 because they submitted a simultaneous approval here, United States, Canada, and Europe. Okay, and that got approved in 2020. And part of the reason of not getting IV Decitabine approved is because the population that's being treated with the oral Decitabine is the same as the IV Decitabine. Okay. And then finally, we got approval of luspatercept in 2021, and both drugs got subsequently funded just probably the last few months. Okay. in Ontario anyways. So luspatercept is a sub-Q injection. The drug works by causing maturation of red cells, whereas for erythropoietin, or Eprex or darbepoetin, it causes a red cell proliferation. So they're slightly different mechanisms, okay? So the approval of luspatercept was based on a phase 3 trial where they compared luspatercept versus placebo in patients with IPSS-R, lower risk MDS, either very low, or intermediate risk, who either failed to respond to Eprex, lost the response, or else were ineligible to receive Eprex or darbepoetin. And they had to be red cell transfusion dependent, but they could not have received lenalidomide or azacitidine or decitabine before. So really a 2-to-1 randomization in favor of luspatercept, which is given every 3 weeks versus placebo. And patients were assessed after 24 weeks, really looking for transfusion independency that lasts, red cell transfusion independency that lasted for 8 weeks or longer. And a secondary endpoint was transfusion independency that lasted for like 12 weeks and longer, okay? And if you had a response, you continued on treatment. So on the bottom left-hand corner is what the responses were. So obviously in blue is luspatercept and placebos in red. And obviously, luspatercept met those 2 endpoints, both primary and secondary endpoint, and you're going to see 38% were transfusion independent for 8 weeks or longer, and then about 28% for 12 weeks or longer. And then it just shows, some other breakdown based on like a 6-week duration or of transfusion independency. So if you had a response, the duration of the response is about 30 weeks, okay, and placebo was only 13 weeks. So this led to the approval of luspatercept for people that have failed or didn't respond to Eprex or darbepoetin and were red cell transfusion dependent, and they had an IPSS score of very low, or intermediate risk. Okay, and then the other drug that got approved was really oral decitabine and cedazuridine. So this is a combination pill, and they combined decitabine with the drug cedazuridine because in the gut, decitabine would be sort of metabolized very rapidly and it wouldn't have any effect. So this stabilizes, prevents it from getting destroyed in the gut, okay? So it's a combination pill. And then they compared it to IV decitabine because the goal of this study was really to show that the pharmacokinetics were similar or the same, had nothing to do with efficacy or anything because the drug is the same active ingredient. They just had to show the FDA that this was the pharmacokinetics were the same. So that's why they sort of included the same patients for which decitabine is approved, okay? And they randomized them 1-to-1. So the first cycle, people got either oral decitabine and cedazuridine versus IV decitabine. And then on the second cycle, the same patient would switch over. If you got IV, you got oral. If you got oral, you switched over to IV. And then everybody was on oral by cycle 3, okay? So the bottom line was that it met its primary endpoint, and that's why the FDA approved it, and subsequently Canada and also in Europe. And on the bottom, it just lists sort of the complete remission rates. Again, remember this drug is similar to azacitidine. It's the same class of drugs. And the CR rate was about 22%. And if you factor in the hematological improvements, meaning the improvement in red cells, platelets, and neutrophils, it was overall response rate of about 62%. And survival, when they looked at it, was about 31.7 months, which again appears longer than what was seen with azacitidine. Remember, I said it was about 26 months. And that may be slightly because the population in this group of study, a lot more were intermediate 1 risk as opposed to intermediate 2 and high risk. Okay. So this is just a very simplified schematic of what we think about when we're talking about treatment for patients with MDS based on patients, characteristics, sort of their comorbidities, whether it's a therapy or de novo MDS, and also based on the subtype of MDS they have, and also the IPSS scoring system that they fall into. So it's always divided into lower risk and higher risk. And right now it's just because of the timing of when studies were conducted, it was based on IPSS and IPSS-R. And so I'm not really going to go into that much detail, but it really is based on those two groups. And on the left-hand corner, you're going to see how it got approved, and at least for Ontario, what the EAP approval funding process is. So these drugs are all approved, but it's really based on IPSS, IPSS-R. And there's obviously IPSS-M is too new a prognostic scoring system. It hasn't been incorporated to any trials, and they're going to have to wait and see what the validation is first. Okay. So I think the interesting part is the newer treatments that are out there, because they're, phase 3 trials. Remember, these are later stage trials. That means that if they're positive, the company is going to try to get it approved by the regulatory agencies. And, unfortunately, because it's a huger population in the States, a lot of times it ends up being approved in the States before they go anywhere else. Okay. So the 3 lower risk studies that have been done and the first 2 are completed. The last one, they're opening up now. So there's phase 3 upfront study of luspatercept versus EPO, and then the phase 3 of imetelstat versus placebo, and the last one is oral azacitidine versus placebo. So I'm just going to remind everybody, for EPREX, it's been around a long time. I mean, it was first used in people with actually renal failure. But they finally eventually conducted a phase 3 study, which was really finished in 2018 and published. And it looked at people getting EPO versus placebo, 2-to-1 in favor of EPO versus placebo. And the response rate was about 46%, okay? And placebo was like 4%, okay? So that confirms what we've been doing anyways. But it still takes about 12 weeks to see a response, up to 12 weeks. And if you see a response, it's still maybe about 2 years, okay? So back then when EPO was being used, this was like in the early 2000s, late 1990s, it was considered an expensive drug. Like, it's really cheap right now for what the cost of drugs right now. But to try to figure out who would benefit from ESA plus or minus GCSF, the Nordic group came up with this decision model, and it was really based on the amount of red cells you needed transfused per month, and also what the serum EPO level was, okay? So if you needed less than 2 bags or 2 units of red cells per month, and you had an EPO level less than 500, 74% chance you're going to respond to the EPREX. If you had a higher transfusion burden, needing more than 2 or more units a month, or your EPO level is greater than 500, it was only about 7%. The reality is that the government in Ontario will only approve EPREX if your EPO level is less than 500 and if you're lower risk MDS. So most of us give it because there's very little side effects with the drug. We just have to monitor it quickly. Yeah. And it makes a big difference for patients' lives when they don't need transfusions. So again, what they did is, so I told you luspatercept is funded as a second-line therapy if you fail EPREX, okay, or not eligible for EPREX. So they tried to look at it upfront for people that were untreated before, that were red cell transfusion dependent. They had to have an EPO level less than 500, and they had to have lower risk MDS, either very low, lower, intermediate risk, and they couldn't be a deletion 5q because it's a totally separate group of patients that do much better. So what they did is they randomized people 1-to-1 to either luspatercept or EPREX, and they had to get, so the luspatercept is given every 3 weeks, EPREX, is given every week. And then they were assessed after 24 weeks of treatment, again, looking at the proportion of patients that were transfusion independent for at least 12 weeks or longer, and also to see an improvement of the hemoglobin by 15 grams per liter, okay? So what happened is the study is closed to enrollment right now, okay? And the final results are pending. But last year in October, the company actually published a statement saying that the trial met its endpoint. So it was a positive study, meaning that there were, higher proportion, significantly higher proportion of patients were transfusion independent for 12 weeks or longer. And also the hemoglobin increased by at least 15 compared to getting just EPREX. So, in very low to low intermediate IPSS-R MDS. So I think, they're going to obviously be submitting to file with the, FDA to get this approved. So that may change how we think about it. I don't know how that's going to work in Canada. I'm not sure, but how it's going to get funded in Ontario as well too. So that's something else, but it's going to take a while. But they still have to present the final results, which none of us have seen. And the second study that again is completed is imetelstat versus placebo as a salvage for people that have failed EPREX or never responded to EPREX or were not eligible for EPREX. So imetelstat is a telomerase inhibitor. So telomeres are found, or DNA found at the end of chromosomes. So when cells divide, this DNA at the end gets lost and the chromosome length shortens, okay? And that eventually with enough duplications or replications, the cell is going to be, the chromosome will be damaged and the cells will be destroyed, okay? If you have increased telomerase activity, it keeps on adding DNA to the end, so you never get shortening of that chromosome, okay? So what this is an inhibitor to that, and we know that there's increased telomerase activity in a lot of cancers, including like MDS, okay? So what they did is they looked at people that had intermediate, low, or intermediate 1 risk IPSS. They had to have no response or loss of response or not eligible for ESA. They couldn't have received any prior azacitidine, decitabine, or lenalidomide, okay? And they were randomized 2-to-1 in favor of imetelstat, which is an IV infusion given every 4 weeks, okay? Versus placebo given every 4 weeks, because again, there's no other accepted standard of care for patients that have failed like ESAs. So the primary outcome was the same, again, looking at transfusion independence after 8 weeks or longer, and the second endpoint was 24 weeks or longer, okay? And so the study is closed for enrollment, but they published their preliminary results, again, positive study. And when people got imetelstat, about 40% of patients were transfusion independent for 8 weeks or longer, 28% for 24 weeks or longer, compared to 15% and 3%. And the duration of that transfusion independency was anywhere from 1 year to 1.5 years. Obviously, you're continuing to receive drug, okay? So, later this year or this summer, Gerion, which is the pharmaceutical company that makes the drug, is supposed to be filing for FDA approval. There's still a sub-study that's going on, just looking at EKG changes for patients. So what happens in that sub-study, it's only like 45 patients. Our site is still doing that because we were involved in this study. They randomize patients 1-to-1 again to get drug or placebo for 2 cycles, and then everybody gets unblinded, and whoever got placebo gets the study drug because it was a positive study. Okay. And finally, for the lower risk, there was this study that was conducted a while ago with oral azacitidine, okay, versus placebo for, again, patients with intermediate, low, or intermediate 1 risk IPSS score, MDS. They had to be transfusion dependent, but they had to have platelet counts less than 75. So there's not a lot of lower risk MDS patients that are both transfusion dependent and have a lower platelet counts, because most of the lower risk, the predominant thing is really transfusion dependency for red cells, okay? So what they did was randomize patients 1-to-1 to get either oral azacitidine or else placebo for 21 days every 28 days, okay? And after 6 cycles of treatment, they looked at the proportion of patients that were transfusion independent for red cells, or else had a 50% reduction in red cell transfusion dependency. The problem is the 21-day schedule was very myelosuppressive. There was a lot of people that had a lot of neutrophil counts that were low. Some people got really bad infectious complications. There were some deaths. So the FDA halted the study for a while. They made sure that there were plans in place to mitigate that side effect, meaning, and antimicrobial prophylaxis, monitoring the patient a bit more closely. It was resumed, okay? But the company didn't think they would meet their targeted accrual to show a difference. So they stopped the study early, but when they reviewed, the results, it actually surprisingly was, positive in the sense that 31% of patients became transfusion independency for red cell compared to placebo of 11%. And it was at least about 11 months duration if you had a response, okay? And you also see a breakdown of some improvement in either red cells, platelets, or neutrophil counts. So what happened was, and it was underpowered to look at overall survival in this case, okay? So based on those positive study results, they decided to go ahead and do another study with the same drug, which is oral azacitidine, which again is a drug that's already approved for people with AML as maintenance therapy, but to cut it down from 21 days to 14 days every 28 days, okay? And also to look at 2 different doses to see which one would be the most optimal dose to give these patients with lower risk MDS. Again, the same criteria as with the first one. And right now they're just on the part 1, the phase 2 study, trying to figure out which is the appropriate dose to use. And then once they find that out, they're going to go forward with the phase 3, where people will be randomized to get the oral azacitidine 14 days out of 28 days versus placebo 14 days out of 28 days. And what's going to happen is people get 6 cycles of treatment, they get evaluated at the end, and then they get unblinded. So people that got placebo will cross over to get the oral azacitidine. Okay, so that's open for enrollment. We're going to open that also at our center too. But so there's a lot of like interesting drugs that are on the cusp of getting approved. And it's weird that it takes like a decade before another set of drugs get approved, right? I think there was so much excitement when AZA got approved, but nothing has panned out. Okay. So the other thing, talking about higher risk MDS, because again, remember azacitidine, even though it showed this huge survival benefit, in real life, it was only about of survival for people that got azacitidine of 10 to 19 months. It wasn't that 26 months that they saw in the study, and nobody's been able to reproduce that. So, and the complete remission rate was much lower, but it didn't seem to affect survival. So what they've looked at is a couple of combination drugs, again, because AZA is still going to be the backbone for a lot of stuff. It's going to be the phase 3 Magrolimab, AZA versus placebo and AZA. And then the other one is Venetoclax, AZA versus placebo with azacitidine. Okay. So just to remind everybody, this is the phase 3 drug that the phase 3 trial that led to the approval of azacitidine in Europe and in Canada. And it was really comparing azacitidine to what we call conventional care regimen, because we didn't really have a standard at that time. It was either best supportive care, meaning transfusions, or else getting low dose cytarabine, or else intensive chemo, which we didn't usually give for people that were older that we weren't going to take to transplant. So the CR rate is only 17% compared to 8%, but about 45% of people became transfusion independent. But what led to approval was really the overall survival, again, about 24 months versus 15 months. And when you look at 2-year-old survival, it was 51% versus 26%. But again, in the real world, when they look back, because everything is based on real world evidence now, like the outcomes are much lower than that 24 months. Survival is only about 10 to 19 months for whatever reason. Okay. And so this led to a bunch of different combination studies, but this is the original sort of phase 1 with Magro and azacitidine for untreated higher risk MDS. So Magro is an antibody against CD47. CD47 is upregulated the expression on cancer cells. And what it is a signal for a don't eat me signal. So that means that once it expresses in the cells, it's very hard to kill those cells. So the Magrolimab or a bunch of other antibodies similar targeting CD47 will bind to that and allow the cells to be killed. Okay. So they looked at 95 patients. They probably have that updated a bit later, but median age was 69 years. They were IPSS-R, intermediate, high, or very high risk. A good proportion had poor risk or adverse cytogenetics, like 62%, and 26% of the patients had P53 mutations, and 22% had therapy-related MDS. And when you look at complete remission rate, that means getting rid of all signs of the disease, having normal counts. It was 33%. But they also saw a surprisingly good response rate in P53 mutated MDS, and that was up to about 40%. Okay. And the duration of response was about 11 months. Time to getting a response was almost 4 months, but they saw signs of an early response, maybe about the 2-month time point. And when they followed the patients out for 17 months, the median overall survival was not yet reached. For patients with p53 mutated MDS, it was about 16 months. And traditionally, if you had a p53 mutated MDS, your survival is anywhere like from 5 to about 10 months. So that looks positive, but again, it's not a randomized trial. So they went on to do this phase 3 randomized trial of Magro plus Aza versus Aza plus placebo in patients that hadn't been treated for their higher risk MDS. Okay. And so they had to have IPSS-R, intermediate high or very high risk disease. And again, no prior treatment, including none of these treatments that are targeted against CD47 or the SERT pathway, which follows along the same pathway, 1-to-1 randomization. The endpoint was really looking at complete remission rate and overall survival. So the study's been completed. Our center was part of that study, but we don't have any results yet. It may be too early to figure it out. It may be in the next 1 or 2 years before we get some idea of whether it makes a difference or not. And then finally, there's Venetoclax and Aza, and you guys probably heard Venetoclax and Aza got approved in 2018 in the States and probably 2020 in Canada for people that were newly diagnosed AML that were not eligible for intensive chemotherapy. And it's a big game changer because that's what we're treating a lot of our patients with right now. Before it was just azacitidine or, best supportive care. So they actually went on to look at this in patients with higher risk MDS. And the reason is Venetoclax is a BCL2 inhibitor, and we know that there's overexpression of BCL2, which is an anti-apoptotic agent, and that prevents the cells from dying. So when they looked at this in an earlier trial with 67 patients, again, older patients, because a lot of patients with MDS are older, right? And it's a higher risk group. And when you look at the complete remission rate, is about 42%, again, higher than what you see with azacitidine, which is only about 17-20%. And the duration of the response was about 14-15 months. Okay. And again, after following patients for about 13 months, survival was not yet reached yet. Okay. So the only difference is that for the Venetoclax study with azacitidine, the dose of Venetoclax was reduced from 28 days, which is given in AML, to 14 days, which is an MDS. And just because it's so myelosuppressive, it knocks down the counts quite a bit. So it wasn't tolerable. So they went on to do the phase 3 based on sort of the schedule that was shown in the previous study. And again, Venetoclax and Aza versus placebo and Aza in people that have treatment naive, never been treated, newly diagnosed, higher risk MDS, and it's the Verona trial. So again, they couldn't have had any prior exposure to, Aza, Decitabine, Venetoclax, lenalidomide, chemotherapy. Never been transplanted, and they couldn't have therapy-related MDS, but they randomized them 1-to-1 to Venetoclax for 14 days every 28 days with the standard dose schedule of Aza versus placebo with azacitidine. And the endpoints are really to look at the CR rate as well as the overall survival. So again, the study was completed in 2022, but we don't have any signal or any readout yet, but everybody's sort of excited with these newer drugs coming out. So the conclusion is, I guess there's been a lot of things that have happened over the last couple of years with the 2 new classifications. Again, there's some differences with the classification system. Not totally sure how that's going to be incorporated into clinical trials because there are some differences, the way that they classified the subgroups. Again, the IPSS-M is the newer prognostic scoring system. Probably a better breakdown of risk categories for the patients, but again, unclear how well it applies in real world, especially if there's a lot of evidence missing or data missing. And again, I told you before, with next generation sequencing panels, it's not consistent with what's on the panels. So I think CCO has tried to make it a bit more consistent so it keeps sort of those panels on, but that may be a discrepancy, and I don't know what it's like in the rest of the world. And then finally, 2 drugs that got approved, Luspatercept and Decitabine Cedazuridine, and it's funded by, Ontario Health. And then there's a whole bunch of phase 3 studies that have completed, or just one of them just starting, but the other ones that I mentioned have all been completed. So Luspatercept is a positive study. So I think we're going to hear news some time, but again, Canada lags behind the States, so it may take a couple of years. And then there's the issue of once it gets approved, whether it's going to be funded for the different provinces. And then imetelstat is again a positive study, so we're going to have to wait. And then the higher risk group, those studies are complete, but we're going to have to wait. Okay. Thank you for your attention. I'm happy to take any questions.
Much for your presentation, and certainly I certainly is good news for MDS patients with all the new treatments on the horizon. I think for those of us who've been around for a while, you know, in the beginning there were so few treatments. So I hope you enjoyed that presentation, and again, thank you very much for giving up your Saturday and coming and spending time with. That's right. It's a good day. At least it's not sunny outside. We're just going to take a quick break now. You can refresh your coffee and tea and maybe come back in 10 minutes. Just a couple of housekeeping items. I do have parking passes, so if you need them, please see me. We have a number of resources, and Robin has brought sort of one of each, and there's a sign-up sheet. So if there is anything that you're interested in, just put your name down, and Robin will get that sent out to you this week. And I don't know if you do need to use the washroom, you do need a pass, which is just up here on the table, and they're just right outside the door there. So maybe just take about 10 minutes to refresh your coffee, and then we'll come back for our second speaker.